Hello everyone. My name is Dr. Mohammed Saleh Vital. I'm actually a consultant pediatrician with expertise in cardiology from Woolwich, London. Um, I had the privilege to work as a pediatric cardiac ICU registrar in Freeman Hospital, Newcastle upon Tyne, which is in the northeast of England, and is one of the top-notch cardiac transplant centres in the UK. So I take this opportunity to thank Dr. Amrul Hussaini for making me a part of this pediatric cardiology webinar. So today, I've been asked to do a case-based discussion of basically fulminant pediatric cardiac failure. So these are some of the cases which I was a part of in managing whilst I was in Freeman Hospital. So we'll be exploring advanced mechanical circulatory support, both extracorporeal and paracorporeal, and we'll have a brief insight into how we transplanted these kids. So first is a kid with viral myocarditis, a previously fit lad, 4-year-old, presenting with 4-day history of viral prodrome, with quite significant lethargy to an extent that he needed to be wheeled in, and he couldn't keep his head off, like head raised off the bed, and reduced appetite, and slowly he was slipping into acute decompensation and slowly slipping towards cardiogenic shock. So he arrived in ED, tachycardic, hypotensive, still self-ventilating in room air, but increased work of breathing, reduced air entry, bibasally, gallop rhythm, pansystolic murmur, and liver edge of around 4 centimeters below right costal margin, with signs of end organ hypoperfusion, lactate of 5.1, mixed venous sats of around 50s, elevated troponin, more than 35 grand, NT-proBNP, more than 45,000, viral PCR positive for parvo B19 virus. The kid, this is the X-ray, as you can see, cardiomegaly. So many times what happens is when the heart keeps dilating, especially the LV DCMs, the LV apex keeps pushing towards the LV left side. So there's many times when they arrive in our ICU, they have severe left lower lobe collapse. Could be basically LA so distension of the LA so distended that it is impinging on the left main bronchus and thereby collapsing the airway in the left. And a bit of a long-standing DCMs, many times you can see hyperinflation of the chest as well. It's just, due to the severe MR and pulmonary venous congestion, the lungs are trying to compensate by creating an auto PEEP. Yeah. This child then went on to develop severe respiratory distress, needed positive pressure ventilation, CPAP, reduced urine output, ending up on triple inotropes. And as you can see, the echo severely dilated LV, reduced radial and longitudinal systolic function, EF15 Simpson biplane, longitudinal that is suggestive radial, longitudinal MAPC of 8 centimeters, diastolic EA-MV ratio 0.8, deceleration time of 250 milliseconds, global longitudinal strain -13, with spontaneous auto contrast in the LV, severe eccentric jet in the mitral, causing a severe mitral regurg to an extent that it is basically causing diastolic flow reversal in the pulmonary veins, but no interatrial communication. The child on the same day got intubed, ventilated, just crashing. So despite all the medical management, progressive deterioration, lactate of 8.2, worsening acidosis, you're not able to see it actually. So mixed venous sats of 40, cerebral sats of around 42. So arterial venous CO2 difference of around 8 to 10. So the child is just not at all getting better. So I ended up on ECMO. So just before ECMO, LA, as you can see, LV massively distended due to the mitral annular apparatus getting dilated, mitral annular annulus getting dilated. Many times the posterior mitral leaflet gets tethered, so eccentric jet, to an extent that it is basically tracing back into the pulmonary veins. There's no intrathecal communication, and there is massive spontaneous contrast building up. So child needs to be put on VA ECMO, peripheral VA ECMO into the neck vessels. So those of you who are not so aware of what ECMO are, so basically there's cannulas that stick inside IV RA junction, blood siphoned out, goes into a magnetically levitated centrifugal pump, which is an impeller pump, pushes blood into the oxygenator. Basically, what the LV squeezes, the pump squeezes, sends blood into the oxygenator. This does the heart job, this does the lungs job, and that basically oxygenates and comes back into the heart through the carotid into the aorta, and is actually supposed to stay in between the first and second branch junction. So it stays there and then systemically perfuses. So basically bypasses the ventricles. So heart fails, you put on VECMO. Lung fails, you put on VV ECMO. This is a single cannula but double lumen, and as you can see, SVC blood, IVC blood, siphoned out, goes to the pump, pump pushes the oxygenator, oxygenates and comes back into the same cannula and then perfuses the RA-RB into the lungs. So there's no lung perfusion here. I'll tell you all about it, but at the moment you might feel like there's no lung perfusion. Yeah, it's actually, yeah, there's the blood siphoned out and is gone to the systemic circulation. But whereas the blood, it goes back into the RB and then is pushed by the heart. So here you need a pumping heart. So there's the only lung failure, you use VV ECMO, VA ECMO for heart failure. These are some of our ECMO machines we use in Freeman. This is a Medtronic Centromag, and we've moved on to the Quantum Medical Spectrum Charlotte perfusion system. A bit more techy, advanced machine, but it's pretty much the same, does the same job. This is the magnetically levitated centrifugal pump. Here it's a bit of a same centrifugal pump but with vortex kind of a flow. More digitally pretty cool, a lot of touchscreen, and this is still buttons. Both does same kind of a job. This basically both can be used as a short-term VAD as well. And this is the ones which we use to carry in helicopters or chartered aircrafts, like this is ECMO for transport ECMO. We moved from CardioHelp, MacKit's CardioHelp, to Medical Spectrum's Quantum. So we put the kid on ECMO, and the child ends up like this. So the condition just worsened. So this is a very common phenomenon. I'll tell you why this has happened. So this is the venous cannula. Many people think this is where the cannula ends. No, actually the cannula ends here. There's a translucent part and an opaque part. Blood siphoned out, pump oxygenated, and then comes back in the aortic cannula. So these positions are pretty okay. But this lungs were not this bad. The lungs are super bad here. So I'll tell you why this has happened. So basically, RA blood is siphoned out. So the RB has no blood, and the blood comes out in the aorta and it goes out into the systemic circulation. So basically there's no pumping of RB, and there's nothing going into the MPA and into the lungs, right? But how come this? So if there's no venous how does the venous congestion happen? So what basically happens is the heart is actually just not contracting any at all. So it's just stiff. So there's impaired aortic opening. The aortic valve doesn't open. There's no pulse pressure in the if you do an invasive arterial line, and there's absent EDCO2, so reflecting no RB output. But still, the lungs are so super congested, as you saw on the previous slide. It's basically the bronchial arteries. So from the aorta, the right bronchial artery and left bronchial artery, they perfuse the lungs, and venous return from the bronchial veins drain into the pulmonary veins, and the blood comes back into the LA. Now all of this blood slowly accumulates in the LV, and there is an aortic valve is not opening. So LV just keeps distending, and there's increasing LV EDP, and there is increasing LAP, left atrial pressure. All the blood then backtracks into the pulmonary veins, and or there's sort of auto contrast. Blood is just swirling inside the LV, and at risk of intracardiac thrombus, and the pulmonary congestion just keeps getting worse. So basically putting on ECMO. We're trying to rescue the kid by putting on ECMO, but ECMO is actually killing the heart. Increased LV EDP, you have to remember, it causes reduced, it jeopardizes coronary perfusion, and that causes the LV to get even more ischemic. It's dilated, thinned out, and it's like wall stress is so much, the heart is just about to fail and die. So we do something called LV venting. It's a strategy. Basically, here in Freeman, they do arterial atrial flow regulator. This is a device. You perforate the interatrial septum, and then you stick this device in. you can regulate the flow through the orifice. That's why it's called an AFR, atrial flow regulator. So that so pushed into the cath lab. This was put inside, and we decompressed the LA and LV, thereby reducing the pulmonary venous congestion and optimizing the myocardial recovery. So as you can see, this is post AFR. This is the atrial flow regulator which has been put inside, and then the lungs are happy, heart is happy, and now we basically saved the kid. Yeah. So this is the device. This I just wanted to show you how it looks like. As you control the orifice diameter, you can control the flow. And this is how it might look like on echo. And some of the LV venting strategies, flow titration. You can titrate inotropes like Meldenon and SNPs, thereby reducing the afterload reduction, thereby try to open the aortic valve. Or you can do a balloon atrial septostomy, Rashkind, basically perforate the intra-atrial septum. You can stick in an AFR. And then there's devices like intra-aortic balloon pump, then the Impella device, where this is also used in Freeman, but for bigger adolescent kids. Basically, blood siphoned out, goes through the device, so basically bypasses aortic valve and is ejected into the circulatory system. Or you can surgically insert LA and LV vent. So thereby we do this LA-LV venting. So the kid, a few days on ECMO, we did try to wean off ECMO with levosiment and infusion, but to not much avail, persistent ventricular dysfunction. So the child needed more durable support. So on day 7, we put the LVAD cannulas, but in Freeman what we usually do is we put the LVAD cannula. So LVAD cannula, one sticks into the LV, that is the inflow cannula, and then this is the pneumatically driven pump that then pumps, and then outflow cannula sticks into the aorta. So we put the LVAD cannulas, but we use the Levitronic center mag like a short-term VAD on ECMO pump. So these cannulas then go into the circuit, ECMO circuit, with heparin infusion on. By the time we've procured Berlin Heart X-Core IKIS stationary driving unit, once that comes in from Berlin, we then change the LVAD cannulas into the Berlin Heart pneumatic driven pump, and then we start bivalve uterine infusion. So some of the diagnostics we did by the time is basically endomyocardial biopsy, which is the gold standard to rule out myocarditis. So the catheter goes into RA, RV, and then takes a pinch from multiple sites, mostly from the interventricular septum. So this you have to understand, in DCM, already the walls are thinned out. So many times you can actually transmurally puncture the heart. So this itself can actually kill the child, but you have to be really careful. A lot of the interventionists need to be really skilled, and then you do it. And day 10, this was done. They were found in the immunohistochemistry, power B19, and myocyte necrosis. So it was confirmed. Cardiac MRI was done. There's something called inversion recovery images. 7 minutes after post-gadolinium, you find post-contrast enhancements that was found in the LV infralateral wall. So it was even more in the T2 weighted images. So that was actually more suggestive of myocarditis. We started IVIG, 2 grams per kilogram over 48 hours. A lot of that was given, and then even thought of corticosteroids, but it was deferred because of the viral etiology due to the viremia. Still active, we didn't want to worsen the viremia, so we deferred corticosteroids. This is a kid, 3 to 4 weeks later, extubated, rehabilitated, and the child was stepped down into our HDU. We call our HDU, we nicknamed it as Vadsville, because that's where all the children who live on Berlin Heart, they have school teachers come in and they live in our HDU, basically waiting for a heart. So he was in our HDU waiting for a heart on bivalve infusion, aspirin, clopidogrel. So what basically the VAD does is, the ECMO is a continuous flow, so VAD is a pulsatile flow. It reduces the RAS, the renin-angiotensin activation system, and thereby reduces ventricular fibrosis and vascular dysfunction, thereby giving time for the heart to recover. Some myocarditis recover, and you can explant them from the Berlin Heart. They can go home. But so we also give anti-heart failure medicines, beta blockers, ACE inhibitors, diuretics, and Entresto. And 2 to 3 months later, we did try to reduce the LVAD flow, increase bivalve, and we did serial functional echoes, but this child never recovered. So he was just waiting for a heart. Then we have another kid. This is an infant, even more serious, an infant kid with idiopathic restrictive cardiomyopathy, autosomal dominant inherited TNNI3 gene mutation, failing to thrive, increased local breathing, increased diaphoresis, classic heart failure, 7 centimeters, huge liver, distended neck veins, sacral edema, ascites. This was even more sicker kid. Low normal systolic function, but really depressed cardiac function, massive two atrias, restricted filling of the pattern, plethoric IVC, hepatic systolic flow reversal, moderate MRTR. Bioventricle, as you can see, the diastolics, TDI, lateral annulus 7, 8, mitral lateral, and septal E7. E prime. So cardiac catheterization showed mildly elevated RA pressures, capillary wedge pressures 28, pulmonary vascular resistance 4.2 Wood units, so TPG of 14, indicating evolving pulmonary hypertension. So as you can see, it's like an ice cream cone, 2 big scoops of ice cream. This is a very stiff, restrictive RV, and there's a lot of blood swelling in the atrias that gives systemic congestion, pulmonary congestion, plethoric IVC. So this child ended up on BIVAD, LVAD, and RVAD. Yeah, so and then eventually both kids got transplanted. The first kid, after 89 days, got a brain dead donor heart, size matched and ABO matched. But this kid is an infant, so it was very hard to get infant hearts. So after 67 days, got a circulatory dead donor heart and size mismatched and ABO mismatched. So this child had a very stormy course. This did fairly well. Post-op didn't have much of a didn't need any VAS cath or dialysis, AKI, no pericardial effusion. This needed post-op, no graft dysfunction or arrhythmias. Sometimes you develop AKIs, you have renal transplant when you have failed kidneys, when you go on bypass, things like that. But this kid had a stormy course, needed found to have antibody-mediated rejection, needed plasmapheresis around 6 rounds and IVIG. And for those who are not so aware of what DCD and DCD have warm ischemic times, we have to restrict this time as much as possible, whereas the brain dead, because the circulation is dead, circulatory death, whereas this is brain dead, here there is not hardly any warm ischemic time. So that's the advantage of a DBD over DCD. The warm ischemic time, basically the time heart ceases, flow ceases inside the heart. So heart is taken out from the donor and put in the icebox. That time is called warm ischemic time. So there is donor warm ischemic time and recipient. So when you take the heart from the icebox and put it back in the donor, that is recipient warm ischemic time. Both should be less than 30 minutes. Cold ischemic time, the time that heart spends inside the cold box, that is cold ischemic time. I'll tell you more about it. So that should be less than 4 hours. Anything more than that each hour causes 1.8 fold times of risk of primary graft dysfunction, whereas every minute beyond 30 minutes causes 1% myocyte loss of warm ischemic time. So, so these are the devices which are used to carry the heart. So this is a Paragonic Sherpa Pack cardiac transport system. This is a cold static storage. This is called perfusion storage. Here, the heart is still beating, normothermic perfusion storage. This is like an ice box, but it's like a canister where the heart is suspended. There's a fluid inside, and the aorta is anchored onto the lid of the canister. Heart does not touch the bottom, and so basically this device has an app where the donors can chat with the recipients, donor hospital chatting with the recipient hospital. And this is what we use in Freeman. So this is also being used in Freeman, but the problem is this can be only used for 50 kilograms and above, so adolescents. Here, the heart is actually moving. This is actually a moving image. For some reason, it's not moving. So heart moves. So the heart never stops beating in this device. It's called TransMedics Organ Care System for heart. There's for lung, there's for kidneys as well, liver as well. So here the heart keeps beating. It's normothermic, perfused. So how is it different? This is the thing which we use for infants and toddlers, for preschool children and smaller hearts less than 50 kilograms. Ex vivo HAT, heart assist transport, or HeartBox. They use HOPE, hypothermic oxygenated perfusion. So here I'll tell you, it looked like exactly like a photocopier. So I'll tell you more about it. As you can see, yeah. So the heart moves, yeah. Okay, there they basically suspended animation. So the aorta, there's a cannula that sticks inside, and it is maintained in a teardrop way where the aortic valve is kept closed, so they can perfuse. There's a blood and in a solution that is mixed, and then that perfuses the coronaries at low pressure. So there's, and it's put into an ice solution. So hypothermic 8 degrees, 8 and less degrees Celsius, and it's still perfused. So there's some oxygenation happening. Yeah. So this is what is used in Freeman. So as you can see, there's a cannula, bilumen cannula, that basically infuses this solution, this juice, which ex vivo cells, that basically is a hard solution, insulin, heparin, imipenem, potassium. It's a cocktail of many things. 2.5 liters, 2 liters of this, and 0.5 to 300 ml of blood is mixed, and then it's infused into the heart. It's zip tied, not sutured. And then once you take out the cannula, the surgeons just cut, so it's easy for them. So they just zip tie it, and this is an LV vent. It's put inside this, and the perfusion, coronary perfusion pressure is around 20 millimeter mercury. So they put inside this. So there's an LV vent. So it is, heart is perfused, the coronary is perfused the heart. Whatever leftover blood is just vented out through the LV vent from the left side, and from the right side they actually slit open the RA, and it actually sludges out whatever is left. Yeah, and this is the what we saw earlier. The entire system. It's disposable reservoir kit. So this is a study done by Unistar, which says 2.73 hours of flight time with this hat, which is the ex vivo hat, heart box, beyond which there is increasing trend of primary graft dysfunction. So they have to restrict your cold ischemic time to less than 3 hours, and ex vivo hat works as good as TransMedics OCS. So TransMedics OCS, Freeman does use this for, but the technology is not for anyone below 50 kilograms, but anyone beyond 50 kilograms, adolescents, young adults, this is pretty awesome. Heart keeps beating inside, and the advantage is that this significantly reduces reperfusion injury risk, and it's pretty cool. This is one of the articles written by the cardiac surgeon Louise Amelia Kenny and Mohammed Nasser. These are the kick-ass surgeons in Freeman, and there's other cardiologists, David Crossland and Emma Simpson, who's an intensivist. She expertises in VAD. So this is an article for those who are really interested in DCD, DBD, and latest technologies used to transport hearts. This is just a picture of a surgeon who, 1987, I was not even born, Dr. Zbigniew Religa. He did a transplant surgery for 23 hours, and the guy is still alive, and he's watching over his patient and monitoring vitals, and a tired nurse is sleeping by the corner. Thank you so much. I hope this was very useful for you guys. Thank you.